Again, good morning, good afternoon, good evening. Welcome to the TB RoundTable Session 2. The Union, along with Central TB Division, Ministry of Health and Family Welfare, India, is planning the TB RoundTable as a regular monthly sessions. Today's session is organized by USAID supported, the Union-led IDFI TB project, along with the consortium partner KNCV Foundation. This will act as knowledge sharing platform for sharing various experiences across the globe with regard to TB and DRTB. So we have all the guests and participants joined from all over India and abroad. So we will be discussing today about experiences with TB preventive therapy for contacts of TB and DRTB patients. I request Dr. Sachdeva, the Regional Director of Union Southeast Asia, to formally welcome the participants.
Thanks, Rakesh. It's nice to be back again, and I was actually looking forward to this session on TB preventive treatment. Even the entire Southeast Asia region, including India, is now in the process of implementing TB preventive treatment and scaling up TB preventive treatment. So there are some experiences which we have on ground. At the same time, we also are facing challenges, and it's a good platform for us to listen from global experts from WHO, Geneva, country office of WHO, KNCV Foundation, experts from KNCV. Also, we have experts from the program division in India, and other union officials are also present on here. So on behalf of the Union Southeast Asia, I welcome you all to this meeting, and I'm hoping that this will be a very interactive session. We have also included a presentation from the community point of view, a small session from the community point of view. Be as interactive as possible, and look forward to a very fruitful, productive session. And hope we'll keep seeing each other every month, come with a new talk, come up with a new topic, get international experience on board, help you interact with other faculty from other reputed institutions, and with an aim to improve the outcomes and under the program. So over to you, Rakesh.
Thank you.
Warm welcome to all of you again. Yeah.
Thank you, sir. Over to Dr. Mansa. Like, we will straight away move to the academic session now. So over to Dr. Mansa.
Yeah, Rakesh, thank you very much for the welcoming remarks. So we'll just move ahead with the academic session, just not to waste much time. So, and the first presentations that we'll have is from the WHO by Avinash Ankar, who is a medical officer at WHO Geneva. So, but unfortunately, he could not present himself, but we have a pre-recorded video of his presentations. So that's I'm going to share with you right now. Rakesh, I'm having some issues because I think that my sharing is disabled. Can you just give me the opportunity to start? Yeah.
Yeah, now you can share, Mansa.
Yeah. Okay, I see in my screen.
Yes, we can see.
Okay, so is it audible?
Not audible yet.
Mansa, you need to share with audio. While you're sharing, you need to select share with computer audio, then only it'll get shared.
Or misconceptions
So how is it now? It is audible.
around implementing TPT at
Yes,
a programmatic.
yes, it's audible.
Try and make.
Let me just start it again. Okay, so.
Hello, everyone. I'll start by thanking KNCV and the Union India for inviting me to deliver this presentation. First of all, I will make a case for programmatic management because there are so many concerns or misconceptions around implementing TPT at a programmatic scale. So I will try and make a case for TPT implementation, and then I'll share the latest guidance that we have from WHO and provide you a glimpse of what we have in the operational handbook as well. My first argument for TPT scale-up is that TPT really works. It is efficacious, it is safe, and there is no increase in levels of drug resistance with scale-up of TPT in the programmatic settings. The evidence that we have suggests that the current TPTs that we recommend, they provide risk reduction of up to 60 to 90% between those who receive TPT versus those who do not. And the protection lasts between 6 to 19 years. As I said, it is safe. A very small proportion of individuals who receive TPT do develop serious adverse events. And most of the adverse events that we note are self-limiting and reversible. Shorter rifamycin regimens are even safer and have better safety profiles. Risk of drug resistance is another concern that implementers usually raise, but to date, there is no evidence at all showing an increased risk due to implementation of TPT. I'll elaborate a bit on the protection that a single course of TPT offers. And all of these evidences that I list on this slide, you can refer in the operational handbook that I would speak a bit more later. A single course of isoniazid protected the Alaska natives for up to 19 years. Among PLHIV who are TST positive, the TRIO study in Brazil and the Temprano trial in Cote d'Ivoire showed protection up to 6 years. Studies from Myanmar and Indonesia showed the same, and a brief TB trial that was done among PLHIV on ART that and compared 3HP with isoniazid showed similar levels of protection. So most of the TPT regimens that we recommend right now do offer long protection with a single course. The third argument that I want to make is TPT along with ART practically eliminates the risk of TB among PLHIV. And while doing that, it reduces the mortality due to tuberculosis. We have known for long that ART reduces risk of TB. Then why add TPT? What the studies that are shown here show that when TPT is given along with the ART, the reduction of the risk of TB is even greater, and it's close to elimination of the risk. And as I said, the TPT reduces mortality independent of ART, which was shown in the Temprano trial, and a reduction of up to close to 40% was noted in this trial. And this is independent of the reduction that was seen with the ART. The next important thing to note is TPT is relatively safe. This is a randomized. This is a systematic review that was done in 2018, which looked at 23 randomized trials and many non-randomized studies. And although we see some adverse events due to TPT, particularly the 6 months isoniazid regimen, but the need to withdraw TPT is in very small proportion of cases. Like with the shorter regimen, it's only less than 2%. It's a bit more with 6 months of isoniazid. The flu-like reactions, they are again rare, seen largely with 3HP. Hepatotoxicity, which is an important concern of most of the providers, and it's the same thing we see. The isoniazid regimens have increased rates of or higher rates of hepatotoxicity compared to the rifamycin-based regimens. The rifampicin only regimen is most protective for the liver. The risk of drug resistance is a concern that everyone raises when they want to implement TPT in the programmatic settings. But to date, there has been no real evidence from any randomized control trial. So I will show 3 slides. One is about use of rifamycin-based regimens, and this is a systematic review again from 2016, looking at 6 randomized control trials and more than about 7,000 patients data. And what we see is only 6 rifamycin resistant cases occurred in the arm that received the TPT, and 1 in the arm that received an alternative regimen. And what is important to note is the difference between these regimens is not statistically significant. So there is no real increase with use of rifamycin for TPT. With intermittent rifamycin, again, there are 3 studies which looked at this and the close to 5,000 patients data, and 3 cases of rifamycin resistance were noted among those who received rifamycin regimen versus 1 among the control regimen. And again, the difference is not statistically significant. So intermittent rifamycin as well doesn't increase any risk of. We see the same with isoniazid regimens. This is a systematic review done in 2006, which looked at data published to date since 1951. 13 studies were included, about 18,000 patient data in each arms, and the relative risk of emergence of drug resistance was not statistically significant again. So with rifamycin or intermittent rifamycin or isoniazid use, there has been no real life evidence yet, but still this remains a concern for implementers. And what is important to remember is the first step in starting TPT is to rule out TB disease. And once you rule out TB disease, it is actually both safe to give TPT as well as keep the any risk of or concern around drug resistance to minimum. So I'll now quickly provide a glimpse of what we recommend. As I said, we published consolidated guidelines in 2020. And along with that, an operational handbook was published, and the evidence that I presented in previous slides, it actually comes from this operational handbook, and you'll find many important implementation issues addressed in this, and you can draw from this operational handbook for any implementation concern that you may have. So now about guidelines. The guidelines follow a cascade of care approach, starting from identification of the target populations for TPT, ruling out TB disease. We have for the first time a recommendation on testing for TB infection. And there are several TPT options, unlike in the past when we just had the INH. For monitoring and evaluation, the guidance also provides some indicators that need to be monitored both at the national and global levels. So as in the past guidelines, the people living with HIV is the one of the important target populations for TPT. Adults and adolescents should be considered for TPT regardless of the ARV status, the pregnancy, previous TB treatment, immunosuppression, or lack of availability of tests for TB infection. Similarly, infants who are exposed to HIV and should be considered for TPT when there's a contact with a TB patient. Children more than 12 months, TPT should be considered for once TB disease is ruled out. And then we also recommend consideration of TPT following successful completion of a course of TB disease. So if a child has received TB treatment, still TPT should be given as early as possible. The second important group, the target population for TPT, is the household contacts. In the past, we recommended children under 5 years, but now we also recommend individuals aged 5 years and above for TPT, and also individuals who are exposed to drug-resistant TB. And this is for the first time we recommend for this population for TPT. Other populations to consider for systematic testing and TPT, individuals who have clinical risks, like people initiating anti-TNF treatment, those who are on dialysis, those preparing for transplants, or patients having silicosis. Prisoners, healthcare workers, immigrants from countries with high TB burden, homeless, and people who use drugs are another population to consider for TPT based on your own settings. At the moment, since we don't have enough evidence, diabetics, alcohol users, smokers, or individuals who are underweight are not recommended for systematic testing and treatment. Although they could fall into any of the above populations and be considered for TPT. The next step in the cascade is to rule out TB disease, and the symptom screening remains the basis for ruling out TB disease, as it has very high negative predictive value. Meaning, if these symptoms that are listed in the second column are absent, it is very unlikely that the target groups would have TB. So TPT could be considered safely. But on the top of this, we also now recommend use of chest X-ray in PLHIV who are on ART, or contacts who are more than 5 years of age. So absence of the symptoms or clinical signs and chest X-ray abnormality should safely rule out TB disease, and TPT could be considered in PLHIV children, or as well as the contacts who are more than 5 years of age. And there's a slight difference in the symptom complexes that you can see on the slides. For the first time, we have recommendation on use of tests for TB infection, even in high burden countries. And we recommend use of either TST or IGRA. And the tests that were reviewed were quantiferon TB Gold and T-Spot TB. And either of them can be used as a test for TB infection. Recently, we reviewed a few more tests, and there are 3 new skin tests that were reviewed, and the guidelines would be out soon, but an announcement from WHO has already gone out in April. But the point to note is testing is not really required in PLHIV and children under 5, given the very high risk of TB and very high risk of progression to TB disease. So as I said, there are several options for TPT now, not only the isoniazid regimen, we have shorter regimens, the 3 months weekly rifampicin INH regimen 3HP, 3 months daily isoniazid rifampicin regimen 3HR, 1 month regimen of INH rifampicin, and 4 months daily rifampicin regimen as well. All the recommendations and all the guidance that I mentioned in the previous slides, you can access through this platform called WHO TB Knowledge Sharing Platform. It provides all the consolidated guidelines and operational handbook. It has also a mobile. All of these guidance could be accessed on a mobile device as well, and then you can see the links here. And there are training e-learning modules as well, including for TPT on this platform. I'll stop here and thank you and thank the organizers for having me. Thank you.
Yeah, thank you very much. So that was the presentations that we have from Avinesh. So, and if you have any questions, you can put it in the chat. So we'll gather those questions and send it to him. So I'll go ahead with the next presentations. And the next presenter is from Aurum Institute. And they will share their experience of TPT from the African countries. And we'll have Karin, so you can share your screen. Thank you.
All right, I'm making sure there you can all see my screen. I'm hoping as presentation, yeah, okay. Yes. All right, so hi everyone. I'm Karen from the Aurum Institute. We are headquartered in South Africa. We are a local organization that has won a global bid from Unitaid back in 2017. I think some of you on this call have heard about our program and what we've been doing, but what I wanted to do is just update you on where we are, because we, since 2017, have been working with WHO, Clinton Health Access Initiative, the Johns Hopkins University TAG, and the lead of this group webinar, KNCV, on implementing this program across 12 countries, catalyzing more countries, and India is also included in this. So I'm happy to start and begin giving you a bit of a overview of where we are. So Unitaid made this investment over 5 years ago. It started with an investment just to get the evidence that Avinash presented around rifapentine being drug-to-drug interactions between rifapentine and dolutegravir. So the first year was a trial that was taking place, but our goals were to do three things: to generate evidence, to increase the supply of rifapentine-friendly products for patients, and also deliver this product to several countries in a catalyzed manner, where we'd hope that our delivery then would stimulate other donors in other countries to uptake this product going forward. So in supply, we got in additional manufacturers, 2 generic manufacturers, both based in India, that now generate the rifapentine-based formulations, and we've reduced the price from the originator, which was Sanofi, down from $72 to $15 per patient course, and now it's slightly lower with the entry of this second generic. We've procured over 1 million patient courses. This is catalyzed also through our friends in the US government and also Global Fund. WHO has donated some products, and GDF has been also facilitating orders. We have made sure that actually this country has increased right now. We've catalyzed policy and practice with 3HP procurements going into about 46 additional countries to our 12. And in the evidence generation category, there were some key studies that were needed to be funded to move before delivery would happen. And some countries did put holds on their updates to their guidance until they got this evidence. One was Dolphin, I already mentioned that, a drug-to-drug interaction study with rifapentine and dolutegravir, which resulted in making sure that it was safe to co-administer to patients living with HIV. Dolphin 2 is investigating the initiation of ART-naive patients to ensure that the drug levels stay the same for those who are just starting ARVs. TBGC 35 was slightly delayed, but is looking for the dosing of 3HP in children under 2 years old. And then we have some implementation studies. One is called CHIP, which is investigating how TPT can be delivered for child contacts and the best approaches for that. And the choice architecture study, which is looking at an opt-out strategy to increase TPT uptake in ART clinics. So those are the first phase of this project that was moving from 2017 to 2022. And now we have been very grateful to Unitaid for also extending us into 2022 through 2024. As Avinash highlighted in his presentation, there are still some evidence gaps. And in collaboration with WHO and Unitaid, we've requested for funding to look at household contacts, non-people living with HIV, just adults at risk of getting TB, and children under 5. So what we've done is funded primarily 3 additional studies. We'll be doing the Dolphin study for children. We'll be doing Dolphin for moms, pregnant moms, looking at 3-HP and 1-HP in pregnant women with HIV. And then we're doing a comparison study of 1-HP to 3-HP among 2 countries with people living with HIV and 2 countries that household contacts. And India is part of that 1 to 3 study as a site. So just in review of what we've done. So by the end of this quarter of 2022, 56 countries have started procuring 3-HP. This is up from a single country, the US, that was procuring it at the start of 2018 from Sanofi at the price of $72. That price has reduced from 72 to 45 to now 15, and now to slightly lower, about 14.25, with these additional generic manufacturers coming on board. And initially, the manufacturing capacity increased from 180 patient courses, this is coming from Sanofi as well, to over 4 million. This includes multiple formulations that I'll get into. Here's some remarks. I know that we, if you look at the map that you can see up there, we have shaded different countries. So the ones in blue are the ones of the 12 that were the Impact for TB countries. Then we have the non-Impact for TB procurements that occurred mostly through Global Fund and PEPFAR, but others as well. The data that you see on your screen are the target sites of our 12 countries. Some of them have been very delayed, and I think people on this call know why. There was COVID, which was a huge delay, especially for our India country to start, and Brazil. There was also nitrosamine impurities found in some batches initially of Sanofi. And until we determined the levels of safety for those batches and controlled the nitrosamine production for the new manufacturers in McLeod's and Lupin and did some rigorous lab testing, those were delayed and held until we could control that nitrosamine impurity, which is now controlled on all products. So all products come to countries with a certification that they are below the threshold levels that have been recommended. That includes the McLeod's and Lupin products. So you'll see that the numbers that we targeted for, which was around 400,000 patients by the end of this grant being on 3-HP, have not been reached in total yet. These are we need to gather this information from country health systems, so this does take some delays. But I think the one to note is the 72.2%. So as a proportion of all TPT in treatment-naive people living with HIV, now we see in countries that had IPT and 3-HP, 72% are going on 3-HP. And there's a lot of patient and provider preferences driving that number to be as high as it is. And you'll see the overall coverage as well on the treatment-naive people living with HIV. A remark on the household contacts, because I know this is important for the India context. It has been very low in uptake, both the children, mostly we were focused on driving for children and for adults, largely due to programmatic delays, but also due to the just uptake and the funder. The Global Fund and PEPFAR really pushed the product to people living with HIV. And now in this next phase of the costed extension, we hope that it goes quicker and faster and better to household contacts and children. So again, I've repeated some of this, but just wanted to let everybody know that this has been a remarkable project to get the supply capacity moving. So there is adequate supply to cover TPT coverage for all those populations that WHO just recommended. There's McLeod's and there's Lupin, and Lupin has added on an interesting new product, the fixed dose combination, which is a 300 milligram single. It's being produced starting this month, and this will and also mix up options for how you deliver 3-HP. The PK studies are still being conducted on 1-HP with the dolutegravir dosing. This is a study that was referred to by WHO. So we are looking to do a little bit of initial catalyzation of this product in our next phase, driving it to household contacts if we can, and donating some of this 300 milligram single rifapentine product to countries who are interested in starting 1-HP. and they may prefer it to go to a household contact instead of a person living with HIV due to this dolutegravir dosing. I also mentioned this acceptable intake level that was put together for the CPNP of nitrosamine. This has now been controlled. There's a process, and the processes in manufacturing have already shown some of those decreases. We are shipping it at under 20 ppm, and we do certify all products through labs globally. Any purchaser can get this certification, and it will be in your country that there will not be a level of nitrosamines. And the shelf life for all these products is about 24 months. Here's or a provider, I suppose, but this is where the patient really matters. How many pills am I taking when I need to take these products? So initially we started out the first few years with Sanofi's product, which is represented by the red tablets. That was a lot of pills to take, even when you're thinking of 1 HP. We've now moved to this fixed dose combination product of 3 HP. And those who have seen the box can see it comes in 1 box, 3 sheets, 1 for each month, perforated across for a weekly dose, a weekly dose, a weekly dose. So we have many countries who have just given the box to a person living with HIV who walks into their clinic to get their ARVs. They walk with the entire box and just check back in on how they're adhering. Many countries are not requesting the patients to come back in on a monthly basis to see if they're adhering to the product. And so far, we have not had many adverse events in any serious category flagged to us by our ministries of health in our countries. The 1 HP product, the yellow one, is representing the 300 milligram single tablet, and that is a very interesting combination. Going on a 30-day regimen instead of a 3-month regimen, you're taking it daily instead of taking it weekly, and we are curious to see how this will be uptaked and if it's better in a patient preference, if it's better in a provider preference, especially for certain populations that it may be more interesting, especially some of those risk populations that WHO talked about, to give a 30-day regimen for. The other bits that were important to develop during our extension is a child-friendly formulation. It's already been recommended to make this formulation, and manufacturers are in process of developing this. The reason is there's very little short course TPT that's been put into children, largely because we do not understand the dosing that needs to come out of that initial TBTC35 trial. We see that most of the kids that we've seen in our countries are on 6H. We hope that Dolphin Kids will also provide some evidence for kids living with HIV, but we also hope during this time frame that a manufacturer is developing a 150 milligram functionally scored dispersible tablet, and that this tablet will be available to be purchased between 2023 and 2024 in countries that would require it. The 1 HP dosing is not available for children yet, and we hope that this study gets funded and starts moving to be able to determine how 1 HP would be rolled out for kids. And then I won't go through the table of dosing. And then on my final slide, just some TPT uptake information and lessons learned, especially around the population living with HIV, because that's been where the majority of our uptake has been. So we understood that clinical training was really important, and clinical training paired with civil society training really helped. The technical information that WHO provided in their slide deck, disseminating that down to nurses, making easy tools and easy training methods go forward, and understanding TPT and TPT doesn't cause resistance, etc., was important. And then coinciding that with guideline development and ensuring that all the guidelines were developed with the same type of information, same evidence package. Appointment diaries for people living with HIV were very useful to ensure that all the required services that are offered were given to those patients. So sometimes those patients oftentimes enter through OI and through a HIV clinic. Sometimes they come through the TB side of the house or through the maternal child health service doors at clinics. And we wanted to make sure that they were captured in TPT across those service areas. And that integration has really mattered in some countries that have the strongest uptake. Also key was adaptation of M&E tools. I don't think this is any different for any other area, but having the systems in the healthcare sector be able to 3HP as an option as opposed to IPT was important. Eligibility important to have that within the TPT register. It takes date in some of our countries. The multi-month of this giving a box of McLeod's and having the patient just walk with it was very important and really drove uptake and patient empowerment to be able to take these drugs. And they preferred the drug as well over the IPT. The CSO community health worker component was also very critical. We funded through TAG many CSO groups in each country to be advocates, to inform civil society of this product, to drive negotiations at Global Fund and PEPFAR to invest in this product. But also when there were issues or misunderstandings, the civil society groups were empowered to be able to determine the evidence and also be able to kind of counter the myth busting that was required. And also just want to say partner engagement was very critical to catalyze this. Global Fund, PEPFAR, PAHO, WHO, all coming together to support this, to catalyze this in the middle of that time frame instead of right now at the end of the program was critical. And the TB programs and the HIV programs working together to both deliver the same information about 3HP to try to drive contacts and people living with HIV to get on this drug has been important, but it's still a big gap. And I would like to thank everyone on our team, and I would like to thank the Indian government because you all have been supporting the rollout, and we hear that there's a lot of movement that's going to happen quite quickly in India on this product, and we just want to make sure that prevention of TB is a priority going forward. Thank you very much.
Thank you very much, Karin, for the interesting presentations and the information shared with us. So I think that if you have any questions, you can post it on the chat. And later on, we'll also have a 5 to 10 minutes question and answer for the speakers and presenters. So we'll go to the next presentations, and Dr. Christian Mulder will talk to us about the impact of TPT on the impact for TB and evidence generation. Christian is a senior consultant at KNCB Tuberculosis Foundation. Thank you, Christian.
Thank you, Mansa, and thank you, TB Union India for organizing this this webinar and having me speaking to this webinar. I'm very grateful for this invitation, and it's a nice segue from the presentation just provided by Karen, given that I would like to brief you on in the next 10 minutes about the evidence we are generating through the Impact for TB project. So, as Karen just mentioned, in the Impact for TB project, we have several goals, and one of the goals is to generate evidence.
Full screen, please.
Excuse me.
Full screen, please.
Is this better now?
Yes, Christian.
Thank you.
Okay, sorry. So there are 7 studies which I want to mention. Those are Dolphin 2, TBTC Study 35, Dolphin Kids, Dolphin Moms, ChipTB, CAT, and 1 to 3. So Dolphin 2, as already mentioned by Karen, so this was basically the study to determine that dolutegravir-based ART regimens were safe to co-administer with 3HP.
Sorry, your slides are not moving. It went back to the introduction slide.
Okay, let me stop, and then I will try again.
Yeah.
can't.
Can you see my slides now?
Yeah, we can see it. So, but it's still not in the presentation mode. Christian, should I share the presentation for you so that I will not waste much time? Do you think that will be possible?
Do you see now the presentation?
Oh yeah, okay, now it's good, it's okay.
Okay, and if I show presenter mode, yeah, you can still see the slides?
Yes.
All right. So, where was I? Oh yeah. So the Dolphin 1 study showed that it was safe to provide 3-HB next to.
Christian, if you don't mind, could you click on display settings and swap displays? Click on display settings on top. You see display settings? Yes. Swap. Yeah. Click on swap displays there. Click on it.
This one?
Yeah. Great. Thank you.
Okay. And then the next study which is proposed is Dolphin 2. So this one is to really assess the safety, tolerability, and pharmacokinetics of 3-HB and IPT among ART treatment naive individuals. The aim is to complete data collection at Q1 2023. So the next study I wanted to present is the TBTC Study 35, which is led by Stellenbosch in South Africa. And this is the study to look at the PK safety and tolerability study of 3-HB in children. So as Karen just mentioned, there's a lack of evidence on the safety of TPT regimens in children. So in this study, 4 cohorts of children will be included. A group of 0 to 1 year, 18 individuals, that's the target, a group of 1 to 2 years, a group of 2 to 4 years, and a group of 4 to 12 years. And it's really important because this study will contribute to understanding better dosing for child-friendly formulations. The aim is to complete enrollment in Q3, Q4 2023. Then there is Dolphin Kids, and this study is to assess the PK safety and tolerability of dolutegravir-based ART regimens and weekly rifampicin in children living with HIV. So this is a single-arm phase 2/1/2 PK and safety study. This is including children living with HIV below the age of 18 years. And there are 4 groups in this study comparing daily TPT with dolutegravir and versus dolutegravir alone. The enrollment is planned to start later this year, and anticipated results will be hopefully there in Q4 2024. I'm really looking at the safety of dosing TPT regimens. Then there are Dolphin Moms. This is a study led by Hopkins and Oram. As is known, like the highest TB risk for a woman is during pregnancy and postpartum. And it's also maternal TB can result in poor pregnancy and infant outcomes. And up to now, there's not that clear guidance on how to prescribe TPT for pregnant women. And especially, there's hardly any evidence on the short course TPT regimens. So with Dolphin Mums, this is a phase 4 study and looking really at the tolerability of 1 HP and 3 HP among people, pregnant women with HIV on an DTG-based ART regimen. And so the primary outcomes are really looking at targeted safety events, and it includes women who are in the gestational period of from 24 weeks onwards to, I believe, 34 or 36 weeks. The estimated study completion is envisioned for the end of 2024. Then there are TB. So TB is a pragmatic cluster randomized trial looking more into the service delivery of TPT, and is comparing a home-based contact investigation versus the standard of care, which is a facility-based TPT initiation. And this study is being conducted in Ethiopia and South Africa. And there are a couple of aims. So one is to examine the social context in which home-based TPT initiation can work best. So kind of understanding the conditions from different stakeholder groups, how we could best deliver this TPT, and that is studied through a qualitative study. Then the second aim is to determine the effectiveness of the home-based TPT prevention services, and that is really mainly looking at comparing a home-based initiation versus standard of care, and looking really at uptake of TPT and completion. And then finally, we of course would like to understand what's the cost effectiveness of such an intervention where you use community-based health workers or health extension workers to provide TPT in people's households. And this study is quite far underway. We anticipate that it's finished in 2023. Then there's CAT, which stands for Choice Architecture, and that is a study running in Malawi, Mozambique, and Zimbabwe. Sorry, that should be Zimbabwe. Among people living with HIV, and this is a study also looking at service delivery and changing the thinking around to whom to provide TPT, or basically how to provide TPT. So instead of making it like an option to provide TPT to those eligible, this study looks at what if we change that thinking around and make it the default option. So only those with a clear contraindication, they should not receive TPT, but all the others, they should receive TPT. And I show you how we try to accomplish that in Malawi, where we have the default option of providing TPT built into the national HIV EMR, the electronic medical record, which you see in the screen below. So basically, when a provider is walking with a patient through their consultation, the EMR determines automatically whether a patient should receive TPT as well or not, next to their AFVs. And of course, the hypothesis here is that when it's a default option, that the TPT uptake should be higher than a standard of care. Final results for this study are expected in Q4 2022. And the final study I wanted to mention, which is also briefly mentioned by Karen, is the 1-2-3 trial, which is led by Johns Hopkins. And this one is looking into comparing 1 HP and 3 HP in terms of treatment success and safety, both in people living with HIV and in HIV negative household contexts. The third option, or the third aim, is to compare cost effectiveness of these two regimens, including healthcare cost and patient cost. And this study is running or will run in India, Indonesia, Mozambique, and South Africa. So approvals are getting in place now, and we hope to start recruitment in early 2023. So to summarize, Impact for TB is generating evidence on the safety, tolerability, acceptability, efficacy, and cost effectiveness of short TPT regimens among people living with HIV, household contacts, children, and pregnant women. Also generating evidence on optimal TPT service delivery models, including home-based TPT initiation and default prescribing options. And this evidence really should contribute, to removing barriers for TPT uptake. So I would like to thank you, and apologies for the technical hiccup. And I would also like to thank Unilate and all the other partners, including Orm, Hopkins, CHAI, TEC, and Stop TB and WHO for working together in Impact for TB. Thank you.
Thank you, Christian Mulder, for this presentation. Let's move to the next presentation, which is the India's country experience on TPT. Dr. Ravinder Kumar, the TB specialist at the Central TB Division, Ministry of Health and Family Welfare, is with us to present about India's experiences with regard to TPT. So I request Dr. Ravinder Kumar sir to present on this. Pranav, can we go to the slides? Sir, over to you, sir.
Thank you, Dr. Rakesh and Mansa, and organizers for inviting me to present country's experience on TB preventive therapy. As you know, TB prevention is a very important component in view of our NTB targets. So we have already started TB preventive therapy in our country. So I'm now presenting you the overview of TB preventive activities in our country. Next slide, please. Next slide. So these are the major milestones in India. Till 2018, we do have a policy for the TB preventive therapy, especially for the PL-HIV and household contact less than 5 years. It is mostly in the form of INH therapy, 6-month INH therapy. At the same time, WHO guidance was released for the expansion of the group for the TB preventive therapy. In country, we have constituted a group of experts, from clinician to public health experts, microbiologists, to deal with how this TB preventive therapy will be expanded in our country. So a group called as National Technical Expert Group for the TB infection. They conducted 3 meetings between September 18 to May 20. And we have formulated a guidelines based on basically WHO guidance for the implementation of TB preventive therapy in the country. In between time, our very good performance state. Kerala already launched their TPT program. So they have started implementation of TPT in children's and adolescent group with the 6 months of INH and 3 months of RH. In same time, Ministry approved the policy and directives are issued to the states regarding the expansion of this TB preventive groups. On the August 2021, Honorable HFM of India has launched our guideline documents. After that, we have conducted a nationwide TOT, National Training for the Trainers, through SWAS e-group platform. After completion of training, we have started district-wise scale-up plan is consolidated. We have issued a detailed guidance to the state so that they can consolidate their plan district-wise, then it is consolidated and the state level. Then we have a national level national level plan for the scale-up TPT. September 21, effectively we started the implementation of TB preventive therapy in our expanded group. 3 HP courses are arranged by our WHO and Global Fund partners also get their grants, and 194 districts, they have started implementation of TPT in different models. And we also start reviewing the progress of TPT scale up in the country. Next. So now our plan for upcoming years is to scale up TPT as early as possible in our country. So I'm just sharing all of with you our current policy on TB preventive therapy. So people living with HIV, we are following our policy, which is called as treat-only policy. For these kind of household contacts, we are following just to rule out active TB, either by mean of 4-symptom screening or chest X-ray. After ruling out active TB disease, these people may be offered with the TPT in the form of either 6 months of INH or 3 HP, which is a weekly doses in the people older than 2 years of the age. Next target population is children below 5 years of age who are household contacts of pulmonary TB. We are following treat-only policy. Testing is not required. For adults or children more than 5 years and other adolescent and other high risk group, we are following test and treat policy in these contexts. First, we are ruling out active TB disease. After ruling out active TB disease, we are offering testing in the form of either TST or IGRA, whatever available with our respective district or states. After ruling out active TB disease and testing for the infection, if they are found positive on the testing, they will be offered with the TPT. We also piloted TPT in context of DRTB patients. For context of DRTB MDR patient, where we know the FQ susceptibility, we are offering 6 months of levofloxacin. And other group where like household contacts of H monopoly or poly patients who are rifampicin susceptible, we are offering 4 months of daily rifampicin. So we also tried a 3 RH as a TPT introduced in 0 to 15 years of individual in the limited geography. We have very encouraging results from there, and this may be adopted as one of the option of TPT in coming future as a policy. Next, please. Next slide. So, already mentioned you, we have built up the capacity of our program officers in state and district. So, after launch of Honorable HFM, guidelines launched by Honorable FHM, we have conducted a nationwide national TOT through WHO SWASI group platform. Despite a pandemic, we are able to train more than 3,000 trainers across the country. Then we have also conducted rapid cascade through webinar-based training and self-learning modules, which are also presented over the SWASI platform. Now we have started physical trainings. Right now, a physical training is going on at our National Institute. Next. So already mentioned you, we have issued a micro tool to our districts so that they can effectively plan their requirement at the district levels. Okay, what amount of what critical activity they should require to plan and prepare with clear timelines, how they are going to map the contacts, how they take the assumption, what is the expected number of the beneficiary, what is the expected number of TB infection testing is required, how the number of TPT drugs are required. Once these assumptions are applied and plan is consolidated at a district level, then we consolidate all plan into a plan, then it is further into a national level plan. So based on these tools, we have already consolidated all the plans. Now we have a national level figure, okay, how we are going to implement TPT in future, what are the requirements. We have almost 460 plus districts in our country. Out of 460 districts, almost 744 districts already started TPT services in their districts in expanded risk group also. Next slide, please. So now coming to the digital recording mechanism, from starting of the TPT, we have clear-cut understanding that we should have digital recording of our TPT intervention. Initially, we have a Niksha contact tracing module in our recording and reporting software, which is providing us a aggregated data. As an interim measure, during 2021, we have a app which is called TB WHO Preventive TB app. Then we customize it and used in our field. Now we have developed a dedicated TPT module in our recording and reporting system, which is called Niksha, where we can see the life cycle approach, a digital record of all individuals integrated with the patient flow. Next. So there is a lot of political and administrative commitment in the country after the launch of TPT guidance by Honorable HFM. Then respective states also launched their TPT program. As you see our state like Bihar, Himachal Pradesh, JNK, and in the scheme, as well as the governor of Pondicherry also launched TPT in our city. So there is a lot of political and administrative commitment in the country for the rollout of TB preventive therapy in the country. Next, please. So as already told you, we have received around 30,000 of 3 HP courses through WHO India country office for the programmatic implementation and research purposes. And our global fund partners through Akshay Plus and G2.0 project already started TPT in different models in almost 194 countries. Next, please. Sorry, districts. Next. So this is a TPT coverage in our country. As for UNHLM target for up to 2022, we have a target of around 6.86 million people should be put on TPT. We are able to achieve around 1.87 million people, which is around 27% of our target, and around 8 lakh people are put on the TPT. Out of most of these people are put on TPT for last 1 year of the implementation. So almost 8 lakhs, 0.8 million people are already started on TPT in our country. Next. So there are few challenges and priority areas for upcoming years. So expansion of TPT in other risk group beyond household context is under consideration of our national clinical expert. We have recently have a meeting regarding this. Most likely we are going to expand in other risk group also. So we are going to combined with our district level active case finding rounds so that we can cover TPT services also there. There is also need for easy, reliable, affordable point of care test for TB infection. As you know, TST is available, but there is issues with the IGRA because being a blood test, we require use in a form of labs. So recently in our country, a newer skin test, which is called CTV skin test, approved by our Drug Controller General of India. Market authorization is also there. So country is planning to procure these, and negotiation process is already ongoing. We are also planning to expand our shorter regimen for the TPT. Procurement plan is also under administrative approval. As you know, adherence of 6 months of IRH is less than 50% only. So 3 HP is going to be a standard of care in our incoming coming days. We also have some resistance from the private doctors and specialists in the medical college. So we are addressing their concerns through special interaction through professional bodies like we have a national task force for the medical colleges. We have NTSU, STSU. We also have a PPSU workforce in the field to address these issues. So country is very ambitious to expand TPT in next year. Next. Thank you very much.
Thank you very much, Dr. Ravinder Kumar. And from here, we'll go to the next presentations, and Yeremia Runtu from the KNCV Indonesia office will share Indonesia's experience on TPT. So Yeremia, you can share your screen. Yeah, thank you.
Yeah, I'm sorry, Mansa. Could you allow me to share my screen?
Try again now, please.
Okay, wait for that. Duplicate dulu. Yeah. Wait for a minute. Oh. Share yang screen 2. Yep. Could you see my screen?
Yes, thank you.
Yes.
Yeah. Yeah. Good afternoon, colleagues and everyone. My name is Yeremia. You can call me Yere from Yayasan KNCV Indonesia, or YKI, and also as the project manager for Impact for TB in Indonesia. Today I will share Indonesia experience on 3HP implementation. Before I'm sorry for my video. Yeah, before I starting my presentation, I want to take this opportunity to thank you to Union India for arranging this webinar, and also United, ARM, and also KNCV to support the project. Yeah, the journey of 3HP in Indonesia began in 2018 as the initiation phase, where YKI introduced 3HP to MOH. Throughout the year until 2022, we continuously conduct activities to support the implementation of 3HP. We began from one province to implement 3HP, and now Indonesia already expand the 3HP implementation in 6 provinces in 4 PLSIVs, and all provinces in Indonesia for household context. Several milestone activities have been achieved with leadership from both NTP and NAP, which is development of LTBA guideline in 2018 until 2020, and the workshop of training of healthcare workers on 3HP for TB clinic and CST clinics, and drug procurement and distribution, and also routine monitoring and site visit on healthcare facilities. For the first part, what the project and YKI has support in Indonesia from the policy perspective, YKI collaborate with MOH and also national partners to support the development and finalization of several guidelines to ensure 3HP inclusion. Starting 2020 for LTBA technical guideline that adopt 3HP as one of TPT regimen options, and expansion of target population, all ages of household context, and high-risk population. And also for HIV technical TPT for HIV arm, TB HIV National Action Plan, and also updated TB HIV Community Guideline on TPT. From the healthcare information system, back in 2020, only 6 aids captured by our information system. Later, 2021 and this year, TSP data already captured for initiation and treatment completion, both in NTP and NAP information system. In terms of health workers capacity building, YKI organized several workshops for healthcare workers, professional organization, and community as well. Starting in one province, which attended by 854 healthcare workers in 2022. YKI support government initiative to expand 3HP workshops in all provinces in Indonesia, with total more than 400 healthcare workers trained. And for communities, around 93 TB and HIV CSOs, and also professional organization such as pulmonologists, pediatrician, internists, GPs, and also pharmacists. Additionally, YKI adopted Impact for TB job aids into local context and reproduced it for implementing provinces. In 2020, the job aids was only distributed to one province due to limited stock of rifampicin. But in 2022, in order to support national scale up, YKI reproduce and distribute job aids to 6 provinces for NAP and 34 provinces or all provinces for NTP. In order to support the field implementation of 3HP, technical assistance is given by doing on-site visit in time of pandemic. We do a virtual or on-site visit with aims to ensure the implementation of TPT and also 3HP is done according to national guideline, including the recording reporting and also usage of job aids. Monitoring and evaluation meeting also held in healthcare facilities level, district level, and also provincial level in several provinces. In terms of drugs itself, began in 2020, Indonesia began to procure 3HP using government budget, domestic budget, to procure 531 dosage of single rifampicin, and all of the drugs was distributed only to one province due to limited stock that government has procured, and many of them is targeted for household context above 15 years old, and a few of them is only for PLSIV. Later in 2021 and 2022, national SIV program through Impact for TB donation receive FDCs from MacLeod with a total more than 2,500 doses, and it was shipment into 2 batches. And after process of SAS and custom clearance, the FDCs is distributed to 6 provinces, as you see my screen in the left side, which has highest cases of HIV. Yeah, this figure, I want to share about the initial implementation about the 531 doses that I mentioned before. 503 household contacts started 3HP between this period, divided in 5 districts in Jakarta province, and 94% among them complete the treatment, and 30 patients has the withdrawal due to drug side effects. Patient moved to another district where 3HP is not available yet in those period, and 1 patient is on a pregnancy. In terms of PLS-IV arm, so 53 PLS-IV started 3HP in this period, and 98% complete the treatment. After this period, I mean the December 2020 until June 2021, there was stock out of rifampicin, unfortunately, due to supply chain issue for both program TB and SIV. But back in 2020, where the stock is available, so based on the promising result of 3HP implementation in 2020 and 2021, NTP expands the 3HP implementation to all provinces in Indonesia. This figure shows enrollment and completion based on available TPT regimen for DSTB in Indonesia, 3HP, 3SR, and also 6H in 6 provinces in Indonesia, which count for highest TB burden. On this period, the highest enrollment number of 3HP comes from Jakarta province. They start first for the drug with 315 patients. As you may see, that 3 out of 6 provinces has higher proportion of 3HP compared than 6H. And for SIV arm, NAP also scale up the 3HP implementation in 6 provinces, which count for high SIV burden. But due to a limited stock of FDCs that Indonesia received, the 3HP implementation only done in currently in 6 provinces. And as chart, higher enrollment rate on 3HP comes for all provinces. So the proportion of 3SP is more dominant than 6H in semester 1 this year. And the rest of the 3 provinces, Central Java, Yogyakarta, and East Java also have started the 3HP, although the number is quite remain small because they start the 3HP later in this first semester of this year. Yeah, several good practices that we found when we do the on-site visit or meeting with many stakeholders from both arms. From the SIV arm, we found TPT refreshment workshop using the local government funding instead of central government. And also, Karin has mentioned earlier that 3SP prescription in line with ARV schedule of the patient. Psychology counseling service to reduce resistance of TPT among HIV patient, and utilization of messaging app regarding the educating and promoting TPT, and also private hospital engagement in this TPT delivery, especially 3HP. And also for community, after the workshop itself, the healthcare facilities collaborate with as IVCSO to do the educating, persuading, and monitoring TPT. And for household context, some good practice that we found from the field: monthly TPT data validation, and then contact invitation activity during pandemic. Instead of do the house visit, the index case and the contact cases invite to come to healthcare facilities. Health cadres training for contact investigation and TPT using local funding. Multi-sectoral collaboration involving the community leaders, local armed forces to support contact investigation and TPT implementation. And also testimony from the community that trusting a relationship between healthcare workers and patient makes a good acceptance among household contexts. This is my last slide. Several challenges of TPT in Indonesia comes from both arms, such as still limited domestic funding to support the PLS-IV TPT delivery among PLS-IV, loss of opportunity on TPT due to medicine pick up by someone else, a relative or a family member during pandemic, limited number of 3HP logistic, double role of healthcare workers, additional burden since pandemic, and pill burden among PLS-IV, and also several variables is not available yet in the our information system, such as the drug adverse event. And from the household context side, several examination is not yet covered by the National Health Insurance scheme, and TPT delivery is not yet optimal in hospital setting. Low coverage of contact investigation activity, similar problem with the NAP insufficient of TPT logistic, and especially from the community side, refusal due to healthy perception among parents and household contact, and similar also with NAP. Some TPT related variable is not available yet in the system, such as IGRA, side effects, and adverse event. Yeah, I will stop here. Thank you for your attention. Back to you, Mansa.
Yeah, thank you very much, Yare, for the nice presentation. So, and for now, we'll open the floor for question and answers. So we can take one question for each of the presenters, and from there, we can continue with the other sessions. So if anybody has a question, you can raise your hand and direct it to each of the presenters, so we can have one question that they will answer.
Dr. Mansa, yeah. There are 17 questions based on evidences for Dr. Avinash Kanchar that is in the chat box. So all those 17 questions we have written down, we have noted down that questions. We will write down the answers and circulate to all the participants. So this is a commitment from our end. So we'll address those 17 questions as a written answers to all the participants. That's a commitment from our end.
Thank you, Rakesh. Thank you for that information. Yeah. So I'm not seeing any hands up. So if you have any questions for any of the presenters, you can raise your hand.
Yeah. So, presenters are also directly addressing the questions, the answers in the chat box itself.
The chat, yes.
So I think we should move on, and we will have the discussions towards the end also.
Yeah. Okay. So then, in that case,
yeah.
Yeah, in that case, then we can move on, and we move on with the next presentation. So, and the next presentation will be Mr. Manoj Singh. So he's the operational lead project of JET, that the Clinton Health Access Initiation, and they will also share their experience with TPT.
Yeah, Pranati Das is there, so she will speak on behalf of Manoj Singh. Yeah, over to Dr. Pranati Das.
Okay, thank you.
Thank you, sir. So, hi everyone, I am Pranati and I am the project lead with William J. Clinton Foundation. leading their operations, implementation of TB preventive treatment under Project JEET in the country. Just allow me a second to share my screen. Is my screen visible? If you could confirm.
Yes, Dr. Pranat.
Thank you so much. So over the next 10 minutes or so, I'll be, talking about the early learnings from the Project JEET 2.0, which is aiming at implementing preventive treatment for TB in the country. Thank you so much to the organizers for offering us this opportunity today to talk about our initial learnings on field. So very briefly, I'll take you through an overview of the project, briefly on the achievements where we stand as of date, and also talk briefly about the operational workflow, the cascade, and some of the challenges and learnings that we have so far. So talking of the project objectives, I think we're aiming at demonstrating and scaling up models of TB preventive treatment, not only for child contacts, but also all adult contacts of index pulmonary TB patients. We are catering to all public and private sector, all pulmonary patients, regardless of whether they are microbiologically confirmed or have a clinical diagnosis. The key activities include home visits for contact tracing, contact screening, counseling contacts, doing a symptomatic screening, and TPT initiation after ruling out active TB using a chest X-ray test, and then following up the household contacts through their course of treatment to ensure adherence to treatment and successful completion. I'll talk about some of the districts, the intervention districts where we are working, and a select set of 6 districts are those where we are actually having, doing an IGRA test for all 5 and above year household contacts in TB infection before proceeding with the chest X-ray and initiation of TPT. So the algorithm that we follow is to identify the household contacts living with the TB, the pulmonary drug-sensitive TB patient. If they are found to have symptoms of TB, they are then directed for an X-ray screening or even a molecular test to confirm their diagnosis and initiate on anti-TB treatment if diagnosed with TB. If not, then we take them into the fold of TB preventive treatment. For household contacts who are asymptomatic to start with, for children under 5, they are directly initiated on TPT with a medical officer prescription. And for 5 and above household contacts, in our pilot geographies of 6 districts, we offer an IGRA test free of cost to all the contacts. And if they have an IGRA positive result, they are offered a chest X-ray to rule out active TB, and then taken further to initiate TPT. For the rest, for the districts where we do not offer IGRA, we are offering a chest X-ray nonetheless to all 5 and above household contacts, and then taking them through to initiation of TPT. The 6 pilot geographies where we offer IGRA to rule in TB infection, the treatment that is offered is 3 months of HP. And for the rest of the districts, the treatment is 6 months with isoniazid. And over the course of treatment, like I said, our team does routine follow-ups with these household contacts, not only checking for any emergence of symptoms, but also checking for appearance of any sort of drug reactions. So the Project JEET is being implemented in the country with 3 principal partners. WJCF is one of them, and we are working across 6 districts in 11 states of India. And on the map on the right, the highlighted names of the districts are our pilot sites where we are offering 3 HP, and the rest of the districts is where we are doing a chest X-ray to rule out active TB and offering treatment with 6 months of isoniazid. Briefly, so we started operations on ground in April of 21. which was last year. Not all geographies started together. We had a staggered approach, and all the 65 geographies came into action only in January of this year. If you look at, the key indicators that we are working for are, coverage of all household contacts for screening, where we stand at 66%. We have seen a constant improvement, and our teams continue to strive to improve this further. And out of all the people who are screened, then offered a test according to, which district they belong from. And we've been able to bring on TPT little more than 100,000 household contacts, which is about 47% of the target. Talking about the operational workflow, so we start with, the index TB cases, the drug-sensitive pulmonary TB cases that are diagnosed on NICSHARE, which is the national platform for reporting of all TB patients. The first attempt is by a team of telecallers who try making a call to these patients to validate their addresses, to confirm, with the landmark, and also that it is easier for the set of team members who have to go and visit them. Then after having an initial conversation on call, taking a brief consent from these patients to come and visit their homes, we have a team of, staff that move and go to their households to meet them in person, meet all the household contacts, list them out, and screen them, for the symptoms of TB, and also do the needful counseling to go ahead and get a requisite test done, and also, for bringing them or TB preventive treatment for them. So these are the people who remain, continue to visit the households to ensure adherence and outcome reporting as well. So as of now, you can see on the screen, the first level of challenge that we face is with the availability of valid mobile numbers or phone numbers for the patients. A good 10 to 12% of the patients do not have a valid mobile number, and hence it's, it becomes very difficult to reach out to them in the first place. The second big is at a level of consent, because this is a new intervention. Not only patients and communities, but even the private providers and medical officers across public health systems as well are not completely aware of what is the algorithm and what is it that they have to prescribe and how the the operations flow. And hence there is about 20-25% of no consent or denial from patients, and some of it also coming from doctors, and hence it affects our ability to reach out to those families and take them into the fold of screening and TPT initiation. So as of now, we've been able to reach out to about 47% of all the index cases who have been reported on NICSHARE in this period. We've been, the teams have been able to screen their household contacts, and it is in about 25% of all index patients where we have at least one household contact initiated on TB Preventive. I wanted to call out here is, the apprehension or, reluctance of providers, not only families, but even the doctors are hesitant in prescribing TPT to children less than 2 years of age. And the primary concerns have been the fear of toxicity, drug-induced toxicity for these children. So I think those have been the major observations and learnings, and our team continues to strive, to overcome these barriers in kind of coordination with the National TB Elimination Program in all of these geographies that we are working. And we have just completed about 1 year of the project, and we have another year and a half to go, and I'm sure we'll have more learnings to share in the times to come. Thank you, everyone. I will take a pause there and will be happy to take any questions.
Thank you. Thank you, Dr. Pranati. Yeah, thank you. So, yeah, you can just unscreen, stop sharing the screen. We have heard all these presentations from the speakers. Now we have a very important person with us, Saba, the representative of a TB affected community. She's from Touch from TB, the National Coalition of TB affected community, people affected by TB. Saba, could you just reflect your thoughts on the discussions that are going on?
Yeah, okay, thank you, sir. Thank you so much. So, my name is Saba. Hello, everyone. From Delhi, Jahangirpuri. मुझे तकरीबन 2 साल हो गया टच बाय टीबी के साथ काम करते हुए एज ए टीबी चैंपियन, और मेरे अंडर कई 5 टीबी चैंपियंस हैं जो नॉर्थ डिस्ट्रिक्ट में दिल्ली में हमारे साथ जुड़े हुए हैं, और वो भी 2 साल से हमारे साथ काम कर रहे हैं। इसमें मैन हमारे जो काम है हाउस होल्ड करना, जो टीबी पेशेंट्स हैं उनकी हाउस होल्ड करना, उसमें सिम्टोमेटिक जो हैं उनको फाइंड आउट करना, और उसमें ये भी श्योर करना कि कोई 6 साल से छोटे बच्चे हैं उनको टीपीटी मिल रही है या नहीं मिल रही है। चेस्ट क्लिनिक में टीपीटी जो है वो अवेलेबल है या नहीं है, ये भी हमें देखते हैं हम कि उन्हें, क्योंकि हमारे इंडिया में 80% पल्मोनरी केसेस हैं जो दूसरों को फैला सकते हैं। तो इसमें हम सिर्फ स्क्रीनिंग जो है जो टीबी कम्युनिटी है उनकी ही कर पाते हैं। अगर कम्युनिटी ग्राउंड कह सकते हैं कि कोविड के टाइम पे हमने स्क्रीनिंग की, सभी की। ऐसा नहीं कि सिर्फ कोविड की है तो को आगे लेना है। तो ये एक हमारे लिए कह सकते हैं गेम चेंजर है। ये लास्ट मोमेंट पे कहते हैं ना कि कोई एक ऐसी सिचुएशन आती है जिसमें गेम चेंज हो जाता है, तो एज ए टीबीटी जो है वो एक हमारे लिए गेम चेंजर है इन टीबी एलिमिनेशन के लिए। बट एज पर गाइडलाइंस अगर हम इसे इम्प्लीमेंट करते हैं तो इसी तरह अगर मैं ये कहूँ सर कि इसमें हमें बहुत सारी चैलेंजेस भी आते हैं। अगर हम किसी स्वस्थ व्यक्ति को टीपीटी खाने के लिए बोलते हैं तो ये 6 महीने तक खानी है, तो उसमें बहुत से थोड़े से चैलेंजेस हमें फेस करना पड़ेगा कि वो नहीं मिले। फैमिली मेंबर जो है उनको मोबिलाइज करना, इसमें खासकर टीपीटी की जो ड्यूरेशन टाइमिंग है तो जितना शॉर्टर रेजिमेंट करा जाए बेटर है, क्योंकि बहुत लॉन्ग टाइम टीपीटी दी जाती है बच्चों को, और हम ये सिर्फ बच्चों को जो 5 साल से छोटे हैं हम उनके लिए ही टीपीटी यूज क्यों करें, सिर्फ ये अडल्ट के लिए भी हो सकती है। खासकर PLHIV जैसे कि है उनको तो विदाउट स्क्रीनिंग भी हमें देना ही पड़ेगा टीपीटी। तो इस तरीके से अगर कम्युनिटी में हम अवेयरनेस दें टीपीटी के बारे में, कई लोगों को जानकारी नहीं है। एज ए ग्राउंड लेवल पे जैसे मैं काम करती हूँ, मेरे टीबी चैंपियंस काम करते हैं, हमारी कोशिश यही रहती है कि टीपीटी के बारे में लोगों को पता चले कि टीपीटी होता क्या है, उसके स्क्रीनिंग के बारे में बताएं कि अगर लेटेंट टीबी पर अगर सर हम काम करेंगे तभी हम कुछ गोल अचीव कर सकते हैं एज ए टीबी एलिमिनेशन के लिए। क्योंकि हमारे सिर्फ हम जो है हम ट्रीटमेंट अगर किसी के डायग्नोस हो गए उसके सिर्फ फैमिली मेंबर की स्क्रीनिंग कर दी, अदरवाइज वो नेगेटिव आ गए उनको छोड़ दिया गया। बट 2 मंथ 3 मंथ के बाद उनकी ही फैमिली में से कोई एक बंदा फिर दोबारा आ रहा होता है हमारे पास ट्रीटमेंट स्टार्ट कराने के लिए। क्योंकि अगर उसी टाइम पे हम उनको ये टीपीटी दें, मे बी जैसे बच्चों को दिया जाता है, तो वो हम उन अपने जो हमारा जो गोल है उसको थोड़ा अचीव कर सकते हैं। जो ये बर्डन है इंडिया पे हमारे, इसको हम थोड़ा कम कर सकते हैं। सर आई हैव ये और ये भी है सर, जैसे कि हम कम्युनिटी में अवेयरनेस देते हैं टीपीटी के बारे में, तो और ट्रेनिंग भी देते हैं, क्योंकि मुझे ट्रेनिंग टीपीटी के बारे में दी गई थी। अभी जीएससीए के लास्ट वर्कशॉप में हमें टीपीटी के बारे में बताया गया था, और उसमें हमें अडल्ट टीपीटी के लिए कहा था। लेकिन कोशिश हम टीबी को तभी खत्म कर सकते हैं जब ये चीजें आगे हम बढ़ाएंगे, टीपीटी को आगे बढ़ाएंगे। उसके लिए चाहे हमें ट्रेनिंग मिले, ट्रेनिंग देनी चाहिए। कई स्वास्थ्य अधिकारी को इसके बारे में पता है, बट कम्युनिटी लेवल पे किसी को नहीं पता टीपीटी के बारे में। तो प्लीज मेरा करना है, तो उसके लिए हमें जानकारी बहुत ज्यादा जरूरी है, इसकी ट्रेनिंग होना बहुत जरूरी है। हर किसी को टीपीटी के बारे में पता होना बहुत जरूरी है। तो इस बस थैंक यू सो मच, और थैंक यू फॉर दिस अपॉर्चुनिटी। आपने मुझे मतलब बोलने का इतने बड़े मंच पे मौका दिया, और थैंक यू सो मच।
Thank you, Sabha. Like Sabha was highlighting about the need to have scale up the TPT urgently for preventing further tuberculosis and preventing the sufferings of TB. So she was highlighting the need to generate demand, to have policies, to have shorter regimens and accountability. And with accountability, we need to scale up TPT with immediate effect. This was the call that was given by Sabha. I think Blessy Kumar is with us from the Global Coalition of TB Advocates, and she will be able to expand this a better, more from the community mobilization perspective. Over to Blessy Kumar for sharing your experiences. Now, can we have one slide for Dr. Blessy Kumar?
Hello, good evening. Thank you very much. I hope you're still focused, and it's been a long session. So I won't take much of your time. From what we have been hearing, I want to just add a little bit about the need for community engagement. And I want to thank Union, especially Dr. Sachdeva, for agreeing to our request and allowing us a few minutes in this very, very much needed discussion around TPT. So I just want to share about what we have done. There's a major challenge in implementing TPT at the ground level. We all know that. It needs massive demand generation, and this demand generation can only come from the community. And the community, to be able to create that demand, needs information, needs capacity building. I think this is one area perhaps we need to focus again. Like our colleague from Indonesia shared, and also Sabha shared, you know, we are going to be asking people who are well to take the medication. So for that, it needs a really different approach. If people understand, people will own, and when they own, they will be able to demand for the services. So from the Global Coalition of TB Advocates, we unpackaged the WHO guidelines into community-friendly brochure called How to Protect Ourselves from TB. And this was done in collaboration with many stakeholders and WHO Southeast Asia Regional Office. It became really popular. Communities across the region and the globe started using it. So then this year, we got it translated into 8 different languages. We still have demand from our colleagues to translate it into Spanish, Portuguese, Russian, etc., which we hope we will be doing. The next activity, again, which was very important, is to build capacity of communities about what is TB preventive therapy. And along with a Southeast Asia Regional Office and the Africa Regional Office of the WHO, we were able to train leaders from the communities. We did about 30 people from India, 27 and a few from Western Pacific, mainly leaders in the HIV community, leaders of drug user community, transgenders, sex workers, and we trained them on what TPT is all about. And this was a hybrid model of training, which was again much appreciated. And we hope that we will be able to secure funding to take this to the next level, because all the leaders have made their own advocacy plans, which they would like to implement in the near future. But the capacitated advocates have gone on and received funding from other donor agencies to implement this in their own countries. So this is something very good. Once you invest in the communities, they really take this and run with it. We don't need to do anything. So investing in communities, building their capacity is extremely important. The last thing I want to share about is a very interesting campaign that global community and civil society organizations have just put together. We hope that this will really kick off really in a big way. It's called the 146x24 campaign. And it's a campaign that is inspired by the legacy of Dr. Paul Farmer to rally the energy, political will, and funding that is needed to achieve the UNHLM treatment and prevention targets. And this was initially started by Partners in Health, MSF, and Treatment Action Group, and has been endorsed by many civil society organizations across the globe, including the Civil Society Task Force of the WHO on TB. So this campaign is actually meant to claim the rights of people with TB to enjoy the benefits of scientific progress. I think people with TB usually get left behind. So we want to bring them into a place where they are able to enjoy the fruits of that rich research that goes on and the scientific progress. You know, it's about getting staff, space, systems, and support needed to successfully make available today's short regimens for both treatment and prevention. We hear so much exciting news about how the treatment regimens, the prevention regimens have been reduced so drastically, and we want to ensure that this is really available. So what does this 14624 stand for? 1 stands for the 1 month treatment regimen for TB infection, which is TB preventive therapy. Now, treat TB infection, we want to call on everyone to treat TB infection in 1 month with 1 HP. For adolescents and adults who are close contacts of people with TB, including people with HIV and other biological, social, and structural risk factors for TB. And we are also calling for a 3-month regimen, either with 3 HR or 3 HP, for those who cannot yet take 1 HP, for example, children. So that's what the 1 stands for. The 4 stands for 4-month treatment regimen for drug-sensitive TB. Again, we call on people and those stakeholders to treat drug-sensitive TB in 4 months with the study 31 regimen for adults and adolescents and the SHINE regimen for children with non-severe forms of TB. Now, this is a global call, so not just for India. Then the 6 is for 6-month treatment regimen for drug-sensitive TB. We are calling to treat drug-resistant TB in 6 months with the TB Practical and the Xenex regimens for adults and adolescents. And we're also calling for urgent acceleration of and prioritized research and implementation of these short-term regimens so that by 2024, that's what the 24 is for, we can actually move closer to achieving those UNHLM targets for treatment and for prevention. Thank you very much.
Thank you so much, Blessy, for explaining about 146 entities. Thanks so much. I already mentioned there were 16 questions related to evidence, which we will be compiling and sharing with all the people. Other than that, there are some questions which has already been addressed in chat boxes, but there is one question, one predominant question, how to address how to ensure that the treatment is completed, how to prevent the leaks in cascade of care throughout the TPT. This is one question that we all need to think and to answer. Maybe we can hear a line from Dr. Runtu, Dr. Pranati, and Blessina regarding this question: how to address the cascade, leaks in the cascade of care in TPT, how to ensure that people are completing the regimen. Maybe a line from Runtu, if you're there. Bless. Yeah, bless you, Kumar, you can.
Okay, so I think, like I said, we need to have community engagement. Consider communities your support system to ensure rolled out on the ground. Let me tell you that if you go ahead without community engagement, this will be a failure, because people are not ready to take medicines when they are not feeling ill. When you are well, you will not take medicines. Even when you're sick, it's difficult to take medicine. So if you're well, you will not take. So engage with the community, build capacity of the community members. It's like you need to get people to understand. It's like fireproofing your house. Even when there is no fire, you fireproof your house. So it is something like that. Even when you don't have TB, you need to make sure that you are protected against getting TB. So community engagement, capacity building, and innovative models, top-down approach will not work. It has to be bottom-up. Thank you.
Thank you. Dr. Pranati, you want to...
Yeah, thank you, Mr. Rakesh. So on top of what...
you are on mute, Pranati, sorry.
Sorry. So I was saying, community engagement, as Ms. Blessy pointed out, is very, very critical, because awareness and demand generation is, one of the key components to make it success. The other thing which I wanted to call out was, a robust follow-up mechanism, for these contacts who are healthy, who are not feeling sick at all. They need to feel that they are cared for and they are supported through this journey of preventive treatment. And, so follow-up is important, and to be watchful of any ill effects or side effects of drugs if they are facing. And, those need to be completely cared for, so that there is less fear, and that sense of being cared for helps them to sail through these, the months of treatment that they have to complete. And I think good counseling to help them understand the need, and only when they understand it will they be completely, agreeable to completing the course of treatment, regardless of how many months of treatment they are put on. So yeah, thank you.
Yeah, thank you. We need to hear from Dr. Runtu also regarding the question is basically how to prevent the leaks in cascade, how to ensure that people are completing the TPT. Dr. Runtu, any suggestions from your end?
Yeah, hi. Could you hear my voice, Rakesh?
The question
yes, you're
was
audible.
how
You're
to
audible.
prevent the leaks in cascade of TPT. Many people are not completing TPT. So what is the crucial step?
I think two most important aspect. The first one is the community engagement that I think our colleagues said before, because especially household context, it's come from the community, not come from the health facility. So community plays a major role to ensure that the context that no sign of TB could come to the healthcare facility to initiate TPT in our experience. And the second one is the health workers' capacity to ensure that all eligible target population is delivery for get benefit from TPT, especially the short course TPT, such as the 3HP and also 3SR, and come up 1HP. So I think that's the most important intervention, Rakesh, from my opinion. Back to you.
Thank you, thank you. Dr. Mansa, so what should we do now? Like, are there any more burning questions that need to be discussed, or like, shall we close it?
Yeah, Rakesh, I think that there is no more question. As you said that the pending question will even here we can turn the presentations, and we can close the webinar and thank everybody for their participating.
I request
Rakesh, back to you.
Yeah, I request Dr. Manu Matthew, the Deputy Project Director of USAID-led Union-run IDFI TB project, to deliver the formal vote of thanks. Also, the program will be available in the IDFI TB channel and the Union channel, YouTube channel. Over to Manu.
Thank you, Rakesh. Yeah. Thank you, Rakesh. Thank you, everyone, for on behalf of the IDFI TB project, KNCV, and the Union. Thank you all for joining this session. It was a wonderful interaction. Special thanks to Dr. Avinash Kanchar from WHO, Dr. Karen from Aram Institute, Dr. Christian Mulder from KNCV, Dr. Ravinder from CTD, Dr. Yeremia from YKI, Dr. Pranti from WJCF, Ms. Sabha from Touched by TB, and Blessina Kumar from GCTA for their thoughts and their presentations. Thank you everyone for joining in, and hope this NTB roundtable has been a productive discussion and it gave you adequate information. Till the next session, thank you, and thank you for joining.
Okay, thank you.